In this lecture, we will discuss Wellens syndrome, including its EKG features and clinical significance. Wellens syndrome occurs in patients that have recently had angina pectoris, that is ischemic-related chest discomfort in the last 24 to 48 hours, but often present asymptomatic. The EKG shows deep symmetric T-wave inversions in the precordial leads V1 through V6 and sometimes leads 1 and AVL. The deep symmetric T-wave inversion should at least be in leads V2 through V5. The ST segment shows no significant deviation, and troponin levels are below or slightly above the upper limit of normal. These features collectively are referred to as Wellens sign and are caused by severe proximal stenosis of the left anterior descending coronary artery, or LAD. This can be acute or chronic. Okay, so what we're showing here is that we have these deep symmetric T-wave inversions. Okay, so here we have our leads. Notice this is our T-wave. Okay, in this case would be a biphasic that we'll talk about soon. Again, a negative. Remember, we define our T-waves by the terminal portion. Okay, so even though this might be upright, it's this terminal portion here that we define it by. Okay, so again, we have T-wave inversion in V1 through V6, as well as in 1 in AVL, okay, at least V2 through V5, they suggest. Now, in some cases, the initial portion of the ST segment may be slightly upsloping. In addition, you may see these biphasic T waves, as we mentioned. But remember, we said we define T waves by their terminal portion, and the terminal portion of these biphasic T waves are typically negative, and therefore are still considered inverted T waves. Some will actually define the biphasic positive negative T waves as a type A, and the deep inverted T waves as type B. Regardless of the type, just remember these are inverted T waves that we're looking at. Now, of those with acute coronary syndrome that have Wellens syndrome, a majority develop a massive anterior MI and have a high risk of developing heart failure if not revascularized. Angiography is required immediately in order to prevent further damage. The risk of massive anterior MI is thought to be even greater in those with T-wave inversions in leads 1 and AVL, because this likely suggests that we have severe proximal LAD stenosis. Okay, so again, in terms of our LAD, this is our left anterior descending artery. Notice that it's stenosed there severely and proximally. Okay, now let's just review what we discussed before we end here. So Wellens syndrome, okay, is angina pectoris, so that chest pain of ischemia in the last 24 to 48 hours plus Wellens sign. Okay, then we talked about Wellens sign. Okay, usually we said these patients present asymptomatic. Okay, then all of a sudden have these. So they have deep symmetric T waves inverted in leads V1 through V6, or at least V2 through V5, and plus or minus 1 or AVL. Okay, and we said the biphasic positive negative T waves still represent that inverted T wave. So again, this would be the biphasic case where we have this type A, if you want to call it. Okay, notice that it's again negative and inverted. Okay, the same leads in both cases. And here's the deep T wave inversion, okay, that we have here, sometimes considered type B. And again, remember, in both of these cases, there's no significant ST segment deviation. It doesn't meet that criteria for ST elevation MI. Okay, you may have some slight upsloping of the ST segment. Okay, so maybe some slight upsloping here, but really doesn't meet, you don't have any significant deviation. There's normal to slightly increased levels of troponins, okay, but not significant enough that you're really thinking of it. So seeing this is really a key sign and can actually save your patient if you get and treat them immediately. Now, the clinical significance of this, remember we said severe proximal LAD stenosis. It could be acute or chronic. It's most of these patients that get this develop massive anterior MIs, okay? And there's a greater risk if there's T-wave inversion in leads 1 and AVL. Okay, not always present, but there's a greater risk. Okay, as well as an increased risk of heart failure if they're not if there's no revascularization. And again, these patients need immediate angiography to see what's going on and to fix this as soon as possible. Well, that's the end of this lecture. We discussed Wellens syndrome, including its EKG features and clinical significance. I hope you learned something.